Imagine it's your first day on the job as a new internal medicine resident. You're thrown into the deep end, the lion's den, on your first day. Your attending physician hands you a file and says, "We have a patient with hyperkalemia. I need you to take a look." You've studied hyperkalemia for your boards before, but you're not quite sure what to expect. The patient's potassium levels are alarmingly high at 7.5 and they had changed rapidly. You knew that this could lead to some serious complications, including cardiac arrhythmias such as atrioventricular block and ventricular fibrillation. You also know that muscle weakness, paralysis, and paresthesia were common symptoms of hyperkalemia, along with decreased deep tendon reflexes. The attending physician and you quickly spring into action, administering IV glucose and insulin to try and drive the potassium into the cells and out of the bloodstream. You also add a potassium-binding resin to the patient's medication regimen to try and lower the levels. But it's not easy. The patient is now experiencing nausea, vomiting, and diarrhea. Despite your efforts, the patient's potassium levels remain high, and you have to keep a close eye on them. You knew that hyperkalemia is a serious condition and that it requires quick action and close monitoring. Luckily, you are well versed in the therapeutic approach to hyperkalemia. The first step in managing hyperkalemia is to determine its severity. This can be done by assessing the patient's risk factors and symptoms, as well as measuring the serum potassium level. If the patient is experiencing a hyperkalemic emergency, immediate management is required. In such cases, you would start continuous cardiac monitoring and stabilize the cardiac membrane by administering IV calcium gluconate. If there are ECG changes, you would then initiate treatment to shift potassium intracellularly using methods such as short-acting insulin with glucose or inhaled short-acting beta agonist. You would also consider consulting nephrology and critical care specialists and admit the patient to the hospital for ongoing monitoring and treatment. Repeat serum potassium levels would be measured at minimum 1, 2, 4, 6, and 24 hours after treatment. For all patients, it is important to identify and treat underlying causes, review medications, and discontinue or modify dosing of medications that may be contributing to hyperkalemia. This includes decreasing the dose or discontinuation of drugs required to treat underlying conditions, such as RAAS inhibitors. You would also advise the patient to avoid non-essential drugs associated with hyperkalemia, such as NSAIDs and over-the-counter supplements, and start a low-potassium diet, avoiding salt substitutes. A nutrition consult may also be considered. In addition to these measures, you may also consider treatment to remove potassium from the body, such as cation exchange resins, diuretics, or hemodialysis. Repeat potassium measurements would be done regularly until the level is within the normal range, typically within 1 to 3 days. It's important to remember that the effects of calcium salts, insulin, glucose, and inhaled short-acting beta agonists on serum potassium levels are temporary, and repeat doses may be required while waiting for interventions to remove potassium from the body to take effect. You would also keep in mind that cardiac arrhythmias due to hyperkalemia can cause sudden death, and that cardiac membrane stabilization is crucial. Calcium salts, such as 10% calcium gluconate and 10% calcium chloride, reduce cardiac irritability. The effects of these salts last only 30 to 60 minutes, and additional dosing may be required. Calcium salts should result in normalization of the ECG appearance within 5 minutes. It's important to observe the cardiac monitor following initial treatment and repeat the dose if the ECG tracing still appears abnormal. However, it's important to note that calcium salts have no influence on serum potassium levels and therefore should be paired with a potassium-lowering agent. Intracellular potassium shifting is another important aspect of treatment. Drugs such as insulin and glucose and inhaled short-acting beta agonists should be given in tandem with calcium salts if calcium is indicated. Short-acting insulin combined with 50% dextrose is the preferred acute non-invasive potassium-lowering treatment. Patients with glucose levels above 250 mg per dl should not receive D50W, and all patients should be monitored for hypoglycemia hourly for at least 2 hours after administration. Inhaled short-acting beta agonists, such as nebulized albuterol, can also be considered as an adjunct to insulin, but not as a monotherapy. Sodium bicarbonate may also be considered as an adjunct treatment only in patients with severe metabolic acidosis, with a recommended concentration of IV 8.4% sodium bicarbonate. However, it's important to avoid administering calcium carbonate and sodium bicarbonate together, as they can form an insoluble salt that can cause precipitation in the IV line. As the patient's potassium levels slowly begin to decrease, you can breathe a sigh of relief. The attending physician commends you on your quick thinking and actions, and you feel proud of your ability to handle a potentially life-threatening situation. However, you also know that this is just the beginning of your journey as a physician, and that there will be many more challenges ahead. But with your knowledge and skills, you are confident that you can rise to the occasion and provide the best possible care for your patients. Don't be caught off guard on your rounds. Share this vid with other below average or average med students such as yourself to help them actually make a difference in patient care and excel. Do it for the patients, bruv.